Okay, it's 3 o'clock. Welcome everyone. The Asia Pacific Sathya Institute for Human Value Education is very, very pleased to present the AGE set of webinars where we're talking about aging in a graceful manner. Now, I'd like to remind everybody about the house rules for today's event before we start. Firstly, to ensure a smooth experience for everybody and for everybody to have the same amount of fun, please keep your microphones muted throughout the whole discussion. The chat group is active. If you have comments, if you have questions, we are more than welcome to invite anybody to ask questions. Please put it in the chat group. There will be question and answer later. All will be done through chat. We will be responding verbally, but we will not be switching on the mics for participants because we only have an hour. So we want to make sure we utilize the full hour. Okay. When you are in the chat comments, please be respectful of sharing your comments in the chat group. This is a little bit of a formal kind of sharing, so we would like to make sure that it's maintained in that way. So do please make sure that everyone is polite and respectful in the chat. You may keep your videos off through the webinar as we are having as we are recording the session for our use, but do keep your videos off during the seminar. And thank you for following the house rules, and I hope you enjoyed the seminar. Now that more people have come in, so I just did that to give more time for people to come in. I'd like to introduce myself. I'm Associate Professor Dr. Anastasia Jagadeesan. I am the moderator of this event, and I will be sharing with you, and I'll be moderating the event and asking the questions for our wonderful panelists to reply to. Okay, next slide, please. Okay, so I'd like to introduce the panelist. I'd like to introduce first Dr. Malavili. She's the public health physician of Malaysia. All right, Dr. Mala, do you want to say hi? Just to say hi before you, yes.
Thank you, Dr. Anastasia. Hi, good afternoon, everyone. So glad to meet all of you today. Hope you have a great sharing session today.
And I'd like to say I really do thank Dr. Muller for coming in. Dr. Muller has had a recent loss in her family, and she's looking at this as part of her duty to come in, and we are kind of, to a certain extent, dedicating this event to her late father who passed away recently. So thank you very much for being here. I do appreciate the sacrifice and the dedication that you're showing in showing up today. So thank you so much. Okay. Dr. Ravi, she's an oncologist from Singapore. Dr. Ravi?
Hi, thanks. I'm a medical oncologist at National Cancer Center, Singapore.
I thought it was you, so you can put it off. Yeah. All right. No worries. Okay.
Yeah, and I have an interest in uro cancer, so I treat prostate, bladder, kidney, and also geriatric oncology, so older patients with cancer. Thank you.
Thank you very much for sharing. And Ms. Hanusia Pravitiraj, she's a clinical psychologist who's now in Australia. Say a few words, please.
Hi, everyone. Thank you so much for having me here to join part of the panel. I work with children and adults across all sorts of different kind of mental health concerns. So really excited to be part of the panel today.
Okay, thank you very much. So now we shall dive in because we only have an hour and we want to make this a very good session for everybody and for everybody to learn and to be part of the process. So next slide, please. It cannot just be a one way, and we want to show a bit of interaction. So this is for the audience now. One question for all of you. What does support of the aged mean to you? All of us in our families, we have got, we have elderly people in our family. Please, type in your poll. You see a poll out now. Please do the poll for everybody. Thank you. Okay. So the highest level is supporting their physical, emotional, social, and spiritual well-being. That's interesting. So the highest one, everybody agrees that supporting their physical, emotional, and spiritual well-being is the most important. So I suppose that listening to them comes under that. Helping them remain independent with dignity is the second highest, which I tend to agree with. That's really important. And same number of that is providing love, compassion, and emotional support. So ensuring healthcare and daily care comes at the third one. And the last one is respecting, listening to, and valuing their wisdom. Thank you very much for everybody for sharing. So we do see that it's not just one thing. Everybody here does acknowledge and does see that when we're trying to help the elderly, It's not just one thing that we're looking at. We're trying to support aged in many different ways in today's day and age. And with the nuclear family, smaller families, families can no longer support the way they used to. Okay, next slide, please. So what we're going to do, how we're going to go about today is we're going to present some cases. So this family is the first case we're going to talk about. Now, next slide. Okay, so the patient is Mr. Rahman. He's 65 years old. So he is recently diagnosed with advanced aggressive pancreatic cancer, and his prognosis is his estimated 6 to 12 months of life expectancy. So once they found out their cancer, the cancer is quite advanced, and he's only got about a year to live. All right. So he's experiencing significant physical pain, severe weight loss, extreme fatigue, and of course the pain is currently being managed by medication. Now his daily life is very interesting. He lives with his wife in a terrace house in Petaling Jaya, but he does continue to do a lot of volunteer work at the local mosque, and he works 3 days in a shop that his nephew runs, assisting at the sales counter. Now, though he may be in pain, he's doing all these things. He goes to the mosque, he does these type of things. So people have an assumption that he's active, that he's doing things. So they don't know how much pain he is in. So the social situation, he's married with adult children living in different states. Children visit when the work commitments allow. So when work commitments allow his children to come and visit him, he's not exactly all alone. His children are around, but they just don't live with him. Nobody lives with him right now. He's just he and his wife. Okay. So the current situation, the diagnosis was disclosed to his children before Mr. Rahman was informed. His children are struggling with whether, when, and how to tell the prognosis while trying to balance hope, on honesty, and his emotional well-being. So the first thing is they've just found out about the prognosis, that he has got cancer and he's got a very short amount of time to live. So my first question, which is going to be open to all three of the panelists, is when you have a situation when we are told that a family member that we love very much it has got a very short time to live and they don't know yet, okay, what is the best way? What is the best timing? How do we inform the family of what is going on? Who would like to start first?
I'm happy to start if
Okay, since
that
you are the
okay.
oncologist, that would be
Yeah.
the best.
Yeah. So I think this is a common situation I face in my clinic on a daily basis, actually. I think very often families come in even before the patient comes in to kind of give the doctor a heads up that maybe prognosis should not be shared in case it upsets the patient and then they lose hope, right? So they're trying to be protective of their family member. And this is called collusion. I mean, this is working with the doctor to hide the information from their family member because they think they're protecting them from hearing devastating news that is going to then push them away from any treatment or anything at all, and they will give up. So it comes from a place of love and compassion and wanting to be protective of your loved one. But unfortunately, that will be counterproductive in many ways. I think at the start, by colluding with the family, we are not being honest and truthful to the patient. And it's their right, it's their body, it's their disease, their illness. They have a right to know exactly what's happening to them, right? That's the first thing. The second thing is, without that knowledge, the patient, especially in this case, in pancreatic cancer, prognosis is extremely poor. 6 to 12 months is quite optimistic. It can be as short as 3 months if it's metastatic disease. And unfortunately, treatment at this point in time is not very effective. We don't have any good treatment that's going to change that prognosis very much. So without that knowledge, they're not able to do a lot of things that they may want to do. They may have plans, they may have loose ends they want to tie, whether it's relationships, whether it's work, whether it's the will, and all these things are important, will definitely be important for that individual as well. And last but not least, if they were to find this out late, there will be a lot of unhappiness on the patient's part with the family members that will further aggravate the the relationship with the family, and it will be a terrible way to, end when it comes to the time for them to go. So for all these reasons, I will then start the negotiation with the family about informing the patient about the prognosis, the diagnosis at that point in time. So you asked about timing. The timing is as soon as you can. The patient has the right to know all of this, but you need to have the family on your side. Without the family on your side, also is a problem, because they have options. If they think you are, not helpful and you're not interested in the patient's welfare because you want to tell the patient the diagnosis, they may assume that, then they'll take the patient to another doctor or somewhere else, right? And the problem is not resolved because the patient still doesn't know the diagnosis. So I think spending that extra time talking through with the family, putting them in the patient's shoes, then they'll realize that actually, if I was in that shoe, I would want to know myself, because I have all these things that I want to do. I've got very short prognosis. So they may then change their mind, and that's my job, is to get them on board so that at the first sitting itself, I'm able to slowly break the news. But of course, individuals vary. There's some individuals that can accept these things and they want it face up, right? But there are others who will come and say, please don't tell me, doctor, because I rather not know now about how much time I have left. But you tell me what are the treatments, then I'll respect that, right? That's a patient's individual choice. But they must be given that choice. I think that's the critical part to this. Thank you.
Dr. Malar, can you add to that? Because
Yes.
yours may be from other areas as well.
Correct. Thank you, Dr. Ravi and Dr. Anasuya. Just a bit of background. I think I should add that I am a public health physician, but my area of expertise and my clinical experience is in palliative care, where life-limiting and life-threatening illnesses are of concern. So Dr. Ravi told us, from the medical perspective, when is the best time to break the news. Based on my experience in palliative care, and I'm also part of the policymakers, I think it is very important, even as public, as a family member, as a carer, it is very important for us to respect the patient's autonomy. When we say patient's autonomy is the capacity, when they have the capacity to make a decision for themselves, we should honor it. All right. So sometimes our family members or the ones we care for, our friends, dealing with this, and like exactly like what Dr. Ravi said, we will face these conflicts where family members step in and say, no, we don't want them to know. So as long as the person is able to make a sound decision for themselves, it is again about the wants, what we want versus what the patient actually needs. So it is first best to ask the patient whether you want to know what's going on. Are you open to know? If they are open to know, then it's okay to take the next step and we discuss the goals of care with the patient. And then after, it is very, very important for the family to be involved. So we move forward with the family conference. Okay, perhaps the first family conference will just be breaking bad news to the family members, explaining about the disease progression. Like in cases of prostate cancer or some other cancers which are very aggressive, it is very important to let them know the prognosis. Prognostics means here how long the patients have, how aggressive the disease will be, how much the life dynamics are going to change for that patient and their family. So all these are important to be established, and slowly break the bad news, establish goals of care, preferred place of care when they're reaching end of life. All these are important. You see, we Asian communities, sometimes we don't want to speak about this because we feel it's bad feng shui. We'll say, oh no, he's still okay. Why do we want to? But we know what's coming. We know the storm will be hitting soon, and when things can change. Although the given time can be 3 to 6 months, some things can happen very acutely and change the whole landscape. So it is very, very important to establish these basic grounds when breaking bad news.
Okay. Thank you very much, Dr. Malar. Ms. Hanusia, from a mental health perspective, when you're coming to breaking this news, is there anything like advice or how to do it, who to do it with?
Yeah, thank you. Thank you so much for, including me. Definitely. I think it's important to recognize that there are two aspects that we need to look at, which is both the client, the patient's mental health, as well as the caregiver's mental health. And sometimes I think it can be a state where the caregivers, in this case, the children, would not want to break the news just because they feel like they don't have the bandwidth to deal with the news. And to them, it could be, I am not ready to deal with the news of my father is going to pass away, so I'm going to withhold. But I suppose, like what both Dr. Ravi and Dr. Muller had shared, is that it is not so much what the caregiver's thoughts and preferences are. It comes back to basically what the client, what the patient needs here. And yes, it is important to recognize that such a news is going to impact their mental health, right? As what Dr. Ravi mentioned, some patients would be able to say, okay, yeah, you know what, I am ready. I can move on, I can prepare. But whereas there are others who are, this is going to bring out a lot of shock, a lot of grief, a lot of emotional outbursts where they feel like, oh, I've got all these things that I've always wanted to do and I'm not ready. So therefore, I think in planning for their end of life care, they should definitely include psychological help as well, because it is a difficult journey for them to navigate, recognizing that their life is ending and how they want to spend it, but also recognizing that there's going to be a lot of caregiver burden, caregiver stress, and having that either an institution or a person who can actually then take on that role of providing the psychological support for the family would be quite crucial.
Yeah. So basically, please, if y'all are not sure, there are a lot of people here who've joined the group. We've got about 91 people, and so the message to everybody is, if your family member is has gotten a very bad prognosis, please do inform them with their consent. So ask them first, do you want to know? And then if they say no, they don't want to know, it's fine. But don't go behind their back, because somehow something happened last minute. If it breaks the trust in the family, you've put yourself in a very uncomfortable position in the last few months of that person's life. So that is the advice from the panel. Would that be agreed by everybody? Okay. So thank you very much for that very, very sound information. So now the next question I have, as Mr. Rahman comes across as capable and he hides his pain, many people do not believe the amount of pain he is in. With hospital appointments in UH being months apart, he usually went to his local GP when he spoke of pain. They assumed it was food issues and just gave him Panadol and normal pain meds. This led to a delayed diagnosis in the beginning stages of pain, and that led to serious repercussions later. So, when people don't have the opportunity to take people to a private hospital, and you're dealing with an elderly who is in pain, when do we know that, especially when you're talking about things like cancer, which may not have a physical sign other than just pain, that something's wrong? And we really need to not just listen to the GP, because we listen to the GP, then it didn't work, it didn't go very well. So how do we go about it? When do we know when to take somebody for serious checkup? Any of the doctors would like to reply?
I can perhaps speak about a little about this system. You see, when we speak of pain in life limiting, whenever it comes to a serious health related suffering, not just cancer, but any serious health related suffering which is life threatening or life limiting, the pain sometimes may not just be physical, it can be psychosocial, it can be spiritual. So more than, like when you say Mr. Rahman appears capable, so he does not display his pain. Why he doesn't verbalize, look, I'm having pain in my tummy, I'm having pain here, I'm having bony pain, bony aches. While he may not say that, there are certain cues that we can take as a carer. I'm speaking in a general perspective because most of our participants are the general public or a carer. So what you can pick up, the cues that you can pick up is, a person will generally be in low mood. You see, they do not look forward to life. They are not as bright as they used to be. Their appetite may be low. They may not be so communicative anymore. You see, their oral intake will be poor, and they might not be as active, physically active as before. They may not show signs of being enthusiastic about life. Imagine a person who was a very spiritual person, now they have lost some motivation to pray. So pain is not just always physical. So it is important when your loved one shows cue. That means they do not look forward. They are forever moody. Moody is another thing. Anybody in pain, they can be very triggered. They can get easily angry. So if a person is not like that at baseline, these are the simple cues that you can pick up that something is not right. they are losing weight rapidly, loss of appetite. So all this is a sign of other pain, not just physical pain. All
Okay,
right.
thank you. And Dr. Ravi, when do we
Mm,
escalate it from going to a general practitioner doctor, our normal clinic, to
mm.
actually taking them to a hospital?
Yeah. So I think based on the question here, the issue was about delayed diagnosis.
Mm.
And we see this quite often for many reasons, right? Sometimes patients' threshold is high, so they think it's minor things and they brush it off.
Yep.
Sometimes it's because they fear what they may find out. Some people don't want to know. They know something's not right, but they fear that they go and check it. It could be cancer like this case and they can't handle it. So they delay and delay. We see this a lot with breast cancer patients where it's quite obvious because you see a lump and they just ignore it because they know something's not right, but they worry if it's breast cancer, it is a death sentence because they're not aware that there are, treatment options. If you pick it up early, it can be cured to a great extent. So in a situation like him, if let's say the GP for some reason has brushed off his pain and after 2 weeks, you've taken analgesia and all, still nothing has happened. And if you think the GP is still going to brush it off, then go somewhere else, right? I think in Malaysia, the options are if you are insured, then you can walk into a hospital and all these are covered. But many people are not. So funding is an issue. They'll think twice if I have to pay for all these scans and all. You can actually then probably go to another government polyclinic and explain to the doctor. Usually GPs, if they know that the symptom is there for longer than usual and there's something obviously wrong, they will escalate it, right? So I wouldn't say that sometimes not all GPs will brush it off. I think they're all good doctors as well. They will then escalate it. But if there's insurance coverage and the patient can walk into a hospital, then based on the symptom, like if abdominal pain, then you want to go and see a gastro doctor or something. And you have insurance coverage, then that's one of the good things that, you can do in a country like Malaysia, where you can actually technically walk into hospitals and have it covered. But of course, if you don't have insurance, then you may have to go through the public healthcare system, which is okay. But you just have to be very frank with the doctor and explain that this pain has been there, for a while, and I've taken the analgesia, it's still there. That will already ring alarm bells with the doctor, and the doctor will write a referral and escalate. The issue in the public healthcare system, I've worked in Malaysia for 5 years before coming over here, so I know exactly how it works. Is sometimes the appointment times may be a bit long because they are overwhelmed, right? A lot of doctors go to private practice. There's just not enough people in the government service. So if they refer to a gastro, it might be months down the line. And during that period, you'll see exactly this delayed diagnosis. So that is some of the challenges that the healthcare system has, right? And the families will have to decide, shall we take him to private? And then they start thinking about the financial toxicity, right? That comes with it, the cost issue. So it is not so straightforward, I think, in attributing sometimes blame to the individual or their families. There's so many of these considerations. There are cultural issues why patients don't want to come up and address these problems. So I think having these open discussions and knowledge out there will actually help people understand that cancer is not always terminal. And if you pick it up early, there's actually treatment that can help cure them and prolong their life.
Miss Sanusia, in terms of mental health, when we're talking about giving this type of people have delayed medication, they're not sure of what to do. Someone's in pain and they feel helpless. What's the best advice you can give a caregiver?
I think firstly, definitely is just to pay attention and not to be dismissive. I think there is a big misconception. Sometimes it's just this understanding that, oh, if you're old, you will have pain. So you just kind of have to deal with it. And sometimes the elderly might also have the same sort of belief that, no, this is part and parcel of growing old. I just have to tahan. I just have to deal with it. I don't want to burden my children. I don't want to tell them about what's going on. So I think like what Dr. Ravi mentioned, that open communication, to have that safe space in between the family so that the adults, the older adults, would actually have that space to say, hey, look, I've been having this pain that has been ongoing for X number of weeks. And also then for the children to then recognize that, hang on, this doesn't seem normal. I think the on the hindsight, I mean, not on the flip side, what can also happen is sometimes a lot of people might just go into Google first. And I mean, I see it in psychiatry, I see it in mental health. I'm sure it happens with physical health a lot more actually. So they might just go into Google, and while sometimes ChatGPT or Google could say that, look, this is serious, sometimes they could also just minimize it. And so then children as well as the patient could just minimize their symptoms, thinking that this is just indigestion, this is just something mild, let me just deal with this, let me just take my Panadol or my painkillers, and things are going to go away. So I suppose coming back to it, it is really important for children to pay attention to their parents and to take it with a little bit more credit and recognize that there is something here. Let's escalate and let's see what can be done as opposed to being dismissive.
Okay, and in Mr. Rahman's case, with a prognosis of like 1 year, and doctor pointed out earlier that 1 year may be actually rather generous. It might actually be shorter than that. So if you have a cancer prognosis, it might be really short. What is the best thing that a family can do with such a short time left, and saying that that person has some mobility, they have a little bit of mobility, they are sound in mind, but the prognosis is now really short? What is the best thing a family can do in those type of situations? Because for me, the amount of how overwhelming that is very, very high.
So this goes back to the goals of care. Sorry, I just answered, but
No, it's fine. You go ahead.
this goes back to the goals of care, and this is one thing that most oncologists, in fact, all will do at the first sitting with the patient and family, right? Understanding that this is terminal cancer, prognosis is short. Most of the time, the goals of the care would be quality of life, right? We know that it is not going to be curative, so that has to be very clear. Sometimes patients and we oncologists may be at fault as well, in order to give them some hope, may not address this treatment intent bit early on, and tell them, yeah, there's treatment. And a lot of times people think treatment means you'll get cured, right? You'll feel well after that. And unfortunately, that will be very misleading as patients continue to deteriorate over time. So I think getting that in treatment goal and intent clear upfront is very important for all the parties involved, the healthcare provider, the family, and the patient. Once that is clear, that quality of life is important, then addressing symptoms, for example, pain here. Pain has to be addressed, right? Because without the pain, then patient can mobilize, can sleep better, can eat better, right? So we need to address it. But there's a cost to it as well. Some of our best painkillers in terms of pain control also cause drowsiness. Patient will get constipation, nausea, vomiting initially, then they get used to it. So they're all these side effects. So all that need to be balanced out to what patient wants. Because if they're sleepy and drowsy the whole day, if they're not alert, then how are they going to talk to their family member, and what kind of quality discussions can be had, in that situation? So I think for families, the goal is to keep patients symptom-free as much as possible, while maintaining what patient values as quality of life. Quality of life for me and for you may be slightly different. Like a very active person, quality of life actually means being able to go out and meet their friends and walk a little bit or get out there, right? For others, they want to stay at home, and quality of life means completely pain-free. They rather be sleeping the whole day than have even a little bit of pain. So that kind of detail and depth needs to be something you want to go into. I think Dr. Malarveli will have a lot of experience in this, having dealt with, palliative care. So she can probably tell you a bit more.
Dr. Malar?
Yeah, sure. Thank you. I think putting both the panelists' views into perspective, what families can do to support. You see, we must remember that when we have a family member dealing with this situation, we are there to support. You see, sometimes, not always, they say less is sometimes more. Okay, so sometimes we think that we are doing good for our family member or our loved ones, and what we intend to do, like Miss Hanu mentioned just now, they will go turn to Chat GPT. I'm not just quoting Chat GPT here, but you see, you go to multiple sources. It's okay to have a second or third opinion. What else can be done? Because there is no blanket rule that one size fits all, right? So sometimes it's okay to go to second or third opinion, but sometimes families, what they will do, or carers even, they go to multiple sources, and then they become so agitated, they don't know what to do. The condition is continuing to deteriorate, but here they are trying to do aggressive. Now somebody will say, for all these situations, you go to India, you go to this place, and then don't trust modern medicine. You go for it. There's no right or wrong in trying, but there's a very fine line between what works and what doesn't. So it's very important not to be overly optimistic or overly pessimistic. And then they will tell, my friend went for chemotherapy. The second session, he died. You see, it's important to be realistic. Don't scare them, or don't go and tell them you go for this chemotherapy. No, you will definitely be cured. You will be okay. Trust me, in 1 or 2 months. So just be very, very realistic. The carers is very important. Sometimes the patient per se will be a bit agitated and a bit undecided. But the carers, it is important to have a good grasp about what is happening, what are the pros and cons of taking each decision, and our goal is to support them throughout that journey. Sometimes being overly optimistic or overly pessimistic actually can stir the situation into a worse scenario.
Mm. And Miss Anusia, when when the time comes and the person actually has passed on, and the caregivers were tried many things or didn't try enough, what is the mental health effect on the caregivers? So that even though you've cared for them, you've done your part, now suddenly they've passed on. So what would you suggest for the caregivers to ensure that they manage the trauma of the death?
Thank you so much for asking that question. I think maybe just if I were to just kind of rewind a little bit back, just to before the person passes away, what I would add is I think what I've noticed in a lot of families is that with adult children, so not so much as just an adult with young children, but with adult children with aging parents, there is often a semblance of a role reversal, right? Because you feel like your parents are getting older and they become a bit more dependent, right? So they become dependent not just on it could be financial dependence, it could be emotional dependence. They're always calling, they're telling you all their problems, but they could also have this dependence of cognition, in the sense where they depend on you as the adult children to make decisions for them. And often when this happens, what happens with adult children of aging parents is that we take on full control. And we feel like, no, since you're dependent on me, you're asking me all these things, I need to make all the decisions for you. And often this can actually remove the autonomy of the patient, where they feel like, no, this is what I want to do. But then you'll have a lot of argument among the children because they feel like, no, I know better. I'm a lot more educated than you. This is all the things that I've been exposed to. I'm not saying that that's wrong, but I'm just saying that it needs to be taken with a pinch of salt, where at the end of the day, you have to remember that it is still the patient who is in the central, and we are all supporting, right? And keeping that in mind, it's recognizing that yes, at the end of the day, we are not making all the decision for them, and they are still making decisions. And so if your father, or in this case Mr. Raman, decides that, oh, you know what, for the rest of my life, whether it's 3 months or whether it's a 12 months, I want a pain-free life, like what Dr. Ravi mentioned. Or maybe he says, hey, no, what is important to me is I want to maintain my quality of life. It's just remembering that that's what they chose. And therefore, then when the person has passed away, is to really just kind of recognize that while you could have guilt that you could have done more, maybe you didn't do enough, it is to work through and to process that, because at the end of the day, again, they're all still adults are making decisions for themselves. And my take home message always is that you can only do the best with whatever resources and knowledge you had at that time. So there's no mistakes in that sense. So whatever you have at that point with that resources, you made that decision and it worked or it didn't work, and now you know better. Hindsight is always 2020, but at that point, that's all you could do. And I guess with that, we have to remember to just kind of, you make space to grieve, you make space to feel sad, you could feel angry. There's a lot of stages of grief, but then you have to work on letting go of the guilt, because there's nothing else that you could have done at that point. If you knew more, you would have done more. But if you didn't, that's all you could do.
Thank you, Doc. Thank you, Ms. Hanusia. There's a question here. Dr. Raman, Mr. Raman has many activities. So maybe one person answer this. And I'm going to actually maybe ask Dr. Ravi, because he works with cancer. Would it be advisable for him to give up or stop those activities since he's given such a short prognosis? What is the preferred outcome?
So actually, this is his choice, right? So if let's say his choice is he wants to focus on prolonging his life or quantity of life, and that means having to go for treatment, and that means taking on the side effects of treatment, right? Now, the clinical judgment about offering patients treatment will fall upon a discussion where we call something called shared decision making between the doctor and the patient, right? So the doctor will say, if I give you this treatment, maybe it will be able in pancreatic cancer prolong your life between 3 to 6 months more, right? But in that 3 to 6 months, you may have all these side effects, which means you may not be able to go out and do these activities that you're used to doing. Then that is a critical decision point for the patient, right? The patient can say, okay, fine, I want to live that 3 months extra because I want to see my, granddaughter graduate, or I want to see my granddaughter or grandson get married, or some event, right? So we work with sometimes these critical events that are important to the individual, and perhaps the drug may help them cross over. We can't promise anything, all these things are out of our control. But if that's the case, he needs to take into account the drawback may be his quality of life may drop during the treatment period, right? He'll live longer, tumor may shrink, but the side effects of the drugs may overwhelm him. So in that kind of scenario, he needs to accept that these activities have to be scaled back, because when on chemotherapy, well, most of these therapies, your immune system is suppressed and you can't go out to crowded areas where you're at risk of getting infection. So that includes places like, let's say somebody mentioned in the thing about going to surau or helping in the mosque where there are a lot of people. He can't, because if he gets an infection, it will overwhelm his system and he may die from sepsis, which is blood infection. So these are the precautions, right? In the food, you must have cooked food. And some people, their favorite food may be salads or sushi, sashimi, all that will be out, right? So these are the trade-offs. So at the end of the day, it is what the patient prioritizes as important to him. Now, if let's say the quantity is not important, quality is, and the quality includes going out to these places, then maybe just don't take the therapy, because the therapy is not going to cure you. It's going to buy you time. But if that time is poor quality time and you don't want that, you rather let nature take its course, we will respect patients' belief. And then we focus on the quality of life, which includes, if it means, if he has some energy to go and volunteer in the mosque or places there, then carry on. Then we'll support him through that. That means he has to be pain-free, right? So we try to get the pain out, but balance with, his level of alertness and all that. So ultimately, it's that shared decision making with the patient that's critical.
Yeah. So from my side, one of the important things take away here is have that conversation with the doctors, understand what you're giving up in order to achieve in this kind of scenario. So because of time, I'm going to move to the second case, and I'd like to remind audience to please post your questions in the comment. We will not be taking verbal questions. Okay, so this is the second case. Next slide, please. So the first case was about care that was short period left. Now we're talking about a case where it's long-term care, and the care is going to be, it could go on for years. Okay, so Madam Leong is 71 years old. She has got diabetes, and she has to go for dialysis 3 times a week, and the dialysis center is 20 minutes from their house. Okay, so it's not too far away. And so she has been losing sensations in both her feet and her legs, and she has got worsening her eyesight is worsening because of prolonged diabetes. So her daily life, she lives in a terrace house with her eldest son, daughter-in-law, 2 young grandchildren. So it's a multi-generational household, and there is a live-in maid that helps with the care. Requires regular transport for dialysis and hospital appointments. So her life tends to be go to the center, spend time with the grandchildren, not much other activities that she goes out for because of the weight of the dialysis. So she is widowed with 2 sons and 1 daughter. Her unmarried youngest son and daughter are primary caregivers who accompany her to medical appointments. They don't live with her, but they are the ones that take her for the medical appointments. They live quite nearby. However, her youngest son has recently received a promotion and is concerned that will have less time to support his mother's care. So the family is finding it increasingly difficult to coordinate her ongoing care and transportation. Their home has not been adapted for wheelchair or stretcher access, creating additional challenges to mobility as her mobility declines. So the family is seeking guidance and support to manage her long-term care needs. So this is a case where the family may have started dialysis and started doing everything with the two family members, and they thought, oh, okay, it's okay, we can handle. But as time goes on, you realize that, as caregivers who are caring and loving, they may not be able to handle, as easily or as much as they thought, and it's going on for years. So now it's affecting the next generation. Okay. So the first question I have for the cases, for the panelists is, this kind of scenario is very overwhelming. Okay. So, and the house is not ready, the house, they don't have access in the house, they have to take the caregiver. What are the main priorities in a situation like this from a medical point of view? What would the main priorities be that the family needs to focus on, or the patient needs to focus on? Can we start with Dr. Malar?
Yes, definitely. So just as I mentioned earlier, one disease can have multi-domain issue. You see, it
Mm.
causes a dominoes effect, not just on the patient, but also the carers and their loved ones. So here, if you notice, there is a few areas of concern. Definitely the health, which is the physical domain, and then there will be the psychosocial domain for the patient and the carers, and also the environmental domain, right? Okay, so definitely when the son is getting promoted, although he's being able to cater for it all the while, he may have some challenges. So this is where community comes in. So in some countries, especially the higher and middle income nations, right? They have this concept where they call it compassionate communities, whereby the communities are trained to identify who among them need this kind of support and support them. They're trained. But in Malaysia, or more other countries, I will speak for the Malaysian context here. Okay, I think Singapore has a compassionate community setting, and Australia also has it. But in Malaysia, we do have NGOs. Okay, so it is very, very important whether or not we have someone in our family suffering with all this condition. It's very important for us to know such NGOs, such as hospices. All right. So get the attending physician to refer them to hospice. Okay, hospice is the team of healthcare professionals. They are multidisciplinary, and it's a nurse-led setting where they actually come and see the patients at home. You see, some things can be managed at home. As it is, this patient is going to go for dialysis 3 times a week. So you can imagine when the care is poor, recurrent admission, hospitalization, it would really shake things up. So getting hospice to view her at least once a week at home can help manage what can be managed at home. That is one. And for her to go for dialysis, we have these NGOs called Usia Mas. Okay, Usia Mas is a group of, most of them are elderly. It's very beautiful to see how they operate. Most of them are elderly, and they are people who are elderly, who are quite educated. They can drive around, and also these volunteers are very well trained to join the patient, just sit at home with them, take them for banking, take them for hospital appointments, just help, mild cleaning up, companionship. So we can identify this kind of NGOs, we can link it with the patient. So it's very important for the healthcare providers and the carers to know that they have to be an external plug and play system. It cannot just operate on itself. So in this situation, I think it's very important, because financial burden out of pocket, you cannot just think somebody is going for the dialysis in the government hospital. So what? Everything is free, isn't it? Out of pocket expenditure is still an issue. So get them referred to the social welfare. So these are the kind of thing. If the doctor or whoever attending to you or your family member forgets, ask for it. This is why awareness is important. Ask for it, and it shall be given.
Okay. Thank you, Miss Dr. Ravi. You can
Yep.
speak from Singapore as well.
Yeah.
It's fine.
No.
We have Singaporean participants.
Okay. No, I can speak from both actually. To be honest, I think the critical differentiator here is that when it comes to caregiving, there's the formal and informal caregiving. So informal is what we all are used to, which is our family members, and that takes a toll. That's actually a full-time job. When you say sometimes, my younger son is at home or not working or not married, then everything falls on one person, and that's not fair because the informal caregiving is substantial. So in a situation like this is where you need to activate, like Dr. Malareli said, the formal caregiving. And that's where I think the biggest difference is between Malaysia and Singapore. Is Singapore puts a lot of resources in for that formal caregiving. So they have this agency for integrated care. And in the situation that this patient with diabetes has, they will come in and help with many things that the family will find challenging. So one is transport, because what she needs is not just doctor appointments. And doctor appointments includes renal, eye. She needs to get to a podiatrist for the feet. She needs occupational therapists, physiotherapists. So with all these things, it's not going to be so many appointments. Even with so many family members, you can't depend on just dump everything on one or two children to run around like this. They have jobs as well. They have their careers. So here they have agency for integrated care. They will actually have services like sending you for the appointments. They can arrange for some home care services. Let's say meals are difficult because the person is debilitated. Then there's Meals on Wheels. They also help with funding for certain modifications in the house. Let's say later on, movement, mobility becomes an issue. The occupational therapists will come in and set this up. In Malaysia, actually, they depend a lot on NGO, which is unfortunately a good thing. It shows that community is there, but it just means the government is struggling in providing these services. But the NGOs try their best. I think the problem is because the demand is so high. Like my mother was a beneficiary of RCC Hospice in PJ 10 years ago when she had breast cancer, and I'm in the field, so I know I have some connections, right? But people don't know some of these things, and they need to find out. But if there are too many people, also these hospices, they struggle. And I think one good thing is the community in Malaysia is resilient, so they try to come up with ways. The bad thing is the government has no resources to help. So it's all dependent on, everybody for helping their own people. So that's one of the huge challenges that Malaysia struggles with, really the funding bit. Singapore is fortunate that way, but it doesn't mean everybody knows about this, right? Because the communication is important. You have all these services, but for older patients who don't have smartphones or internet savvy ability, they are not able to access this information. So it's there, but they don't know. So sometimes when they come and see a medical professional, then we can help them with this and provide that knowledge. Thank you.
Okay. Ms. Sathya, this
Dr. Anisha, sorry, I just forgot to inform regarding one other service
Go ahead.
other than sorry. So in the primary care setting in Malaysia, please be aware that there is domiciliary and domiciliary palliative care. So hospices that I mentioned just now is focused more on the urban areas. So the semi-urban and rural areas don't have much access. So it is very important to know that you can request for domiciliary or domiciliary palliative care, whereby the healthcare team will come and review the patients at home. They can help with changing these tubes, and they can train the caregivers, and they can also offer some form of palliative care. So please be open enough to speak to your healthcare provider in the hospital. If you can get them referred, if there's the patient bedridden, you can definitely ask for this care.
Okay, thank you very much. Ms. Sathya, when we're talking about this type of issues, what other support should be provided for family and patients in terms of the mental health, long-term sicknesses, in managing long-term sickness?
Thank you, Dr. Anasuya. So I think the main thing here is that the family should recognize that this is not a 100-meter race. This is actually more of a marathon. And I suppose like what both the doctors have mentioned is that load cannot fall on just one person. And I think the main thing that they probably need to start looking out for is for mental health concerns, both for the patient as well as for the caregivers, right? So for the patient, I think mainly what people would want to look out for, apart from the medical issues, is that with diabetes, there can also be cognitive impairment. So there is a high risk of dementia that can happen. And so those are some of the things that you would want to start noticing. If you're, like in this case, with the mother, she's showing more signs of memory loss? Is she more confused? Is she not able to perform the tasks that she can do? Like, for ultimately, we want to maintain her independence. But if we start noticing that there is cognitive decline, there is a bit more struggles mentally, then that's when we want to sort of maybe speak to the doctor, refer her to a psychiatrist, or to get any kind of mental health support. With the caregivers, I think is really what we're looking at is caregiver burden, caregiver stress. And like warning signs of caregiver burden would be things like just feeling a lot of irritability, a lot of emotional exhaustion. So just spending time with mom. So it could be right now is the younger son who's doing a lot, or the younger son and the daughter who's actually taking a bit more of that load of bringing her out for her appointments, but then is the son at home and the daughter who's actually managing the day to day. I think there needs to be a lot more communication, right? And then to notice symptoms like, is anyone who's in the caregiver circle, are they a lot more irritable? Do they feel like they're a little bit more depressed? Is there a lot more resentment coming out? There is a high amount of abuse that has been reported around the elderly. It's important. It's hard to talk about, but it's important to recognize. And one of the main reasons for this is just caregiver stress, right? I'm a caregiver for my parent and I can't deal with the stress, and therefore I flip, I become very abusive. Verbal abuse is still abuse, emotional abuse is still abuse, physical abuse is obviously abuse, right? So it is important to recognize the symptoms in us. If we are feeling resentful, if you're feeling like, oh my God, I just don't want my parents to be around, they're so troublesome, then that's resentment. And that is a sign that you do need to go and seek help. And I think there are agencies, there are services available. Even if there aren't any in public health, can always go and speak to a psychologist, speak to a counselor, so that you have that space to vent, you have that space to think about what exactly is going on, where is this resentment coming from, and what can I do? If the load is entirely on me, maybe I can now, split that role a little bit more with either my family members or both informal and formal care, so that it is not completely on me, right? Sometimes there's also guilt that comes in. And then because of the guilt, we feel like, no, I have to be there all the time. And then that goes into depression. I become very withdrawn. I am not able to function at work. So I guess that's a caregiver burden that can actually lead into more psychological problems. So I guess those are the two things to look out for.
Okay, thank you. We are actually opening it now for questions from the audience. I will ask one more question just while you all are typing. If anybody has anything to type, please do type your question now. I did answer a question earlier that somebody posted, but if anybody has extra question, you can ask now. But I have a kind of a statement, or following what Ms. Anusia said. I have seen cases where very rich, they have their family is in a good situation, but the main caregiver is the maid. And so under the skirt, below the waist, there was a lot of bed sores, damage under the waist that were hidden, and it was continuous. So even though they go to doctor for one, there's another one after that very soon. That means that, we need to understand that with the elderly, especially in certain areas, they won't tell you. And if you're letting the maid look after, the impact of it can be tremendously terrible. There is actually abuse that happens on a daily basis. Okay. Ratna, you want to click for the question and answer page? So I just want to put out there as a warning. So sometimes we do have to take a look and make sure that they're okay. So is there something wrong with the technical side? Okay, last question for everybody. When it comes to diabetes, is there anything else is there any hidden issues that might come up in terms of medical for diabetes that maybe that people are not aware of?
I think the main thing is it's a multi-organ disease. So a lot of people think you just control the sugar. It's not just that, right? Of course, you get good control, everything else will fall in place. But classically, of course, in our medical training, will be micro and macrovascular disease. So you're looking at your heart, your stroke risk, and then the other microvascular ones will be your eyesight, your nerves. So it's a multi-organ thing. And when you go to most GPs are quite well trained in picking up some of these things and are able to then refer to the specialist when, let's say, there's damage to the kidney, then they'll refer to kidney specialists. When there's damage to the eyes, they'll refer to eye specialists and so on. But I think it's important for people to be aware it's not just the blood sugar, it's not that number alone that in long, because a lot of them may have had occult diabetes for many years before checking. So a lot of the damage may have set in and they just brush it off as, oh, my eyesight is poor because of old age, or I see a lot of frothy urine, and then they may brush it off and say, yeah, it's just something I drank. Yeah. So I think just make sure that you go to a doctor who can evaluate all these things and send you to the respective specialist.
Okay, I think somebody else is asking in the audience is what this question is not answered. How to break the news? The answer to how to break the news is break the news with the doctor. Discuss with the doctor how to break the news and break the news as soon as possible. But is there any other like a magic way to break the news to somebody that they've got a serious sickness? Dr. Ram, you have to unmute. Yeah.
Can
There
I?
are some techniques, but please, Dr. Malwari, you go ahead. I've spoken too much.
No
Please.
problem, Dr. Ravi.
Yeah.
After you.
No, it's okay. It's okay. You carry on. I can add on. Yeah.
One good way to break the bad news is first to explore how much they know. Okay, so it is very important to speak to the patient and ask, you're going from their perspective. What do you know so far? What are your experiences throughout this period of time before you actually came to seek help? And have you asked around, all these points to something? What are your insights about this? So gauge their understanding first and pick it up from there, rather than just straight away say, I know I have personally seen breaking bad news happening, like the physician is putting his hands in the pockets, looking at the computer and saying that, oh, looks like you have so and so cancer and it doesn't look good, you may just have very few months left, so we got to do something about it. That's definitely not the best way to do it. So it's very important saying that you've come here, so what have you experienced so far? Do you have any idea? What do you think is happening? And gauge it from there. That is my suggestion. Thank you.
Yeah, I fully agree with that actually. So what I wanted to say was we teach this to all our trainees, medical officers who come through oncology, because unfortunately every consult I have is bad news, right? It's oncology, it's cancer, right? So we have to find ways to ensure that patient gets the right information and are able to come out of it supported. So we use something called SPIKES, SPIKES. So SPIKES, S stands for setting. So you want to be in a private area where patient doesn't feel like other people are overhearing this, and must be comfortable, not noisy, and all that. P is perception, as what Dr. Malavadi said, is really what the patient knows, right? So I won't go through that. Then I is invitation. So then you invite the patient to ask you, about what they think they have and whether it's okay for you to share. That's the critical point, because that's where sometimes things like prognosis and all may come up, and then you want to know where they are in terms of their knowledge and how much more they need to know. That means you're trying to fill in the gaps. And K is that the knowledge, right? So as a medical healthcare professional, my job is to fill in any gaps they have and correct misconceptions. Very often they come in with all these misconceptions about cancer, cancer therapy. E, empathy, and last one is I summarize. Sorry, I know you're right on the dot on the time, so I'll stop there.
Yeah. I have just a couple of very short answer questions, please. Somebody's asked, is there a ministry that is in charge of that can help seriously sick patients? Is there a ministry that can help them, like for elderly, geriatric, or seriously sick patients?
Kementerian Kesihatan Malaysia.
Other than that, Dr. Malar, are you aware of any other
Okay,
ministry?
there is also a role for the welfare ministry to play. Sometimes even Kementerian Wanita and Pembangunan
Yes.
Keluarga, they do come in and support in initiatives related to breast and other female related cancers. Then the Kementerian Wanita comes in, and then other than that, the local state exco Kesihatan will also have many programs under their belt to actually support the community in social related expenditures apart from
Okay.
Ministry of Health.
All right. Okay. I'm sorry. Okay. Thank you very much for answering that question. I'm sorry that we are running out of time, and it's a very interesting conversation. And thank you all for coming in with the questions. We can't go through all the questions at the moment. If some of the questions, if you really wanted, we can stick around after we finish this part of it. So, even if you want to know more, we are going to have the Age webinar. It continues. It's not the first one. So please join us for the future webinars, and you scan this code that we're showing right now for future webinars that we're going to be having. Okay, and then also to join as a participant in the community, where we're trying to set up a community to support people in aging gracefully. Like they said, in Malaysia, we don't have that support, but maybe we can start a movement to get that support. All right, next slide, please. Okay, so you also mark on your calendar, the next event is on the 22nd of August. It is the mental agility, use it, don't lose it. So this is about how to keep your mind agile as you age. This is open to every age, because we all need to know, as we mentioned earlier, one of the major issues in mental health is the cognitive capacity reduces. So when we talk about mental agility, it helps you increase your cognitive ability, because your brain has plasticity so you have that plasticity in your brain. You want to grow it. You want to ensure that you keep that agility as you age. All right. So 22nd August is the next one, and there are a few more, so do join. And please, your feedback matters. So as I'm closing, I'd like to open this for anybody who wants to give feedback. Please send us that thought, and let's just see whether our panelists can stay a little while. And as everybody gives their feedback, we will see about some of the questions. Okay, so somebody's asked cheaper rates under Unimas to cover for diabetic patients. What is the minimum age to qualify? Please check the websites of this service providers. They will have their details there. Those are not details that we can say now, in case we say something that we don't represent the NGO, so we don't want to say anything that's wrong. I'm sorry, I don't really understand about funeral burn and the corpse. I think I need a little bit more information. I don't understand the question. What I'm not sure about that. I do not understand the question. I'm sorry about that. And okay, yes. All right. So if there's any other questions that I'm trying to see whether I've missed out any important questions. Okay, fear of death. Is there something after if they okay? So when you talk about fear of death, it depends on your belief system. It's not for us to judge what happens after somebody dies in this scenario. In terms of mental health, I can talk about, because I do work with thanatology, I do work with death quite a bit, and each individual, even in the same family, same religious background, you can have different levels of fear of death depending on your relationship with death itself and your relationship with God. So the answer can be very long for a very short, seemingly question. Okay. Um, so there are lots of differences in family, but I think I'll just leave the answer at that, unless any of the panelists want to talk about fear of death. Feel free.
As in,
Anusha?
is it for the client, for the patient, or for the caregivers?
maybe for all, just in general.
I
Just a
suppose,
few
I mean, if it's,
sentences.
I think at the end of the day, it comes back to your religious and spiritual belief. So I suppose that's when you want to engage more people. Like if we're talking about the first example with a Muslim person, this is where you can actually involve the imam. They might find a lot of solace in actually speaking to someone and spending the end of their lives with, with regards to what the religion prescribes. And I suppose the same can actually be said about the caregivers too. So religion can provide a lot of solace, a lot of answers. And if it doesn't, I'm pretty sure there are a lot of materials out there. And also you could speak to a therapist to actually explore your fears a little bit more in depth. Because there's definitely beliefs and negative thoughts that we have about death in our head that contributes to the fear. So it's worth talking about it and not suppressing it. That's my 2 cents.
Yeah, we're just giving a little bit of time for people to ask questions now. Can we go back to the community
Sentence.
page? Ratna, can you please go back to the community page? Yeah.
Can I
Okay.
have
So some
one
people.
sentence to the statement, Dr. Anasia?
Yes,
Yes,
sure. Go
please.
ahead.
Fear
Yeah.
of
Sorry.
death. Okay, moving apart from the religious spectrum, right? Some of us are religious, some are not. I just want to share that we all have to know that death is inevitable. We all know that, but the idea of embracing the fact. So it is very important for us all, in the Asian community, we do not want to speak about that. We do not want to hear about that. We don't even want to be around the news of death. So I think it is time to unlearn these things and break the taboo and understand that death is inevitable. We can't run away from it. How do we embrace it? How are we planning for our last days? There are things that, of course, sudden deaths can happen, but it is very important for each and every one of us to understand and plan how we are going to die if we have a chance to
No,
plan.
I'll definitely agree. I think one thing, if I could add, is in a lot of the, I suppose more of the Western communities, there is this thing called death doulas, which is it's such a beautiful concept because it's basically like you have birth doulas where you have women who support women through birth, but there are also people who then support people through their end of life and figure out what is going to happen, and that's not religious based. And the death doulas basically really just journey with you through that end of your life process and support the family. It's such a beautiful thing, and I guess the main thing is to break that taboo. That yeah.
Correct. I work a lot with death and dying, and I will say this: in Malaysia, we do need to be a little bit careful because we tend to rely a lot on family and extended family. And one of the biggest problems I have seen when it comes to death and fear of death is because you don't talk to your family about death. When someone dies, nobody knows where the money is, nobody knows where the emergency stuff is, and people get cheated quite a bit by the extended family at that point in time. So those discussions have a very practical reason, not just a medical reason, where you need to not be afraid of talking about death. It's really important. Somebody asked, is homeopathy recognized in Malaysia? It's not recognized by KKM. It's recognized by the Ministry of Alternative Medicine. What's it called? There's another ministry. It is recognized in a secondary ministry.
TCM, it's
Ah,
TCM,
yeah. So there is a
traditional and
ministry that covers
complementary.
tradition. Yes, the Ministry of Traditional and Complementary Medicine. It is covered under that. And if you're not sure about your practitioners, you can go to look under the Ministry of Complementary and Traditional Medicine, and they can actually help with those type of things. But homeopathy is recognized under that ministry, not under anywhere else. Not by
Some of
KKM.
the
KKM.
health ministry facilities also have a TCM unit. Some places like IKN, and I'm not too sure exactly where, but you can enquire with them. Some hospitals do have an in-house TCM unit.
Hmm. Somebody said here, my cousin did not tell my mom she had cancer. I followed his advice. My mom asked, I have cancer. I said no. Well, I mean, that's, I think what was said earlier, that is your choice to do that. But it's a lonely place when you take away your mom's. It depends on your relationship with your mother and what your mother is like, and whether your mother is comfortable. But you have taken away that choice from her. So, I mean, at the end of the day, that's where the family has a little bit of power, and that has to be your choice. We can't really say anything else about that. Is there a support group for seniors to join? That's an interesting question. Well, they can join the community, and from the community, then later on we can create support groups. I think that's something the organizers are looking into. I think that's something that will happen, that can
Apart
happen
from
from
that,
this.
in Ministry of Health, there is this thing called Kelab Warga Emas for Malaysians. This is in the Malaysian context. So you can go to the nearest district health office or clinic kesihatan and ask if they have Kelab Warga Emas. Trust me, they are doing an amazing job to promote inclusivity among senior citizens.
Yeah, I also want to tell you all that there's actually quite a few localized support centers in Malaysia where they do provide mental health support. They do provide extra care support, and it's usually in your. You can ask your state representative about it. You can get it from your state. It does come from the state. Government also has, but state also has. Dr. Ravi, you've got something to add?
Yeah, no, because I think one of the questions was integrative medicine and
Mm,
complementary care in hospitals.
yes.
The answer is yes, actually, yes. So even my center, we have an integrative oncology clinic where we provide acupuncture, and in the near future, traditional medicine. We've got a few experts coming from overseas. There's data to support yoga, And that's from the physical point of view. And definitely there's much more that some of these medications and therapies can help as well. And I think we see the value. The critical thing is the data. So we're trying to do research in the space as well, because some of these things interact with Western medicine. So people must be aware, although they say herbal, but herbal, all our chemotherapies are herbal, by the way. They are from barks of tree, sea plankton. They're from natural sources. So, and they are very toxic. So don't assume that if somebody tells you this is herbal, it's natural, that it will not cause any problems, right? So, yeah, I'm at the National Cancer Center. Somebody asked for the website. So National Cancer Center Singapore, and you'll be able to find that information there. Thank you.
When we are taking any kind of remedies, which are, you've got medical remedies, and then you have got your spiritual, your cultural, your TCM, traditional medicine. Please make sure they are not clashing. Okay, because some TCM medication requires you to take food, but your food may have sugar in it. Whatever they're having, they may have hormones in it. So you kind of need to know when to balance what you're doing. You have your medical, and you do need to follow. If not, you're actually going to be kind of counteracting each other. So you need to be careful when you're doing it. Please do inform your doctors when you are taking traditional medicine, especially if you're taking something into your mouth. If you're going for prayers and all that, that'll be fine. You don't have to tell your doctor. But as soon as you're taking something into your system, physically taking something into your system, then I do believe you need to talk to a doctor. Dr. Malar, you want to chime in on that?
I must say this is very important to know, because whether we like it or not, there are some people out there making big bucks out of people who are sick. Okay,
Yeah.
so they'll come and tell you this. I have seen countless of our patients coming up when every resource that they potentially have be drained out, and finally they turn up to the Cancer Institute in stage 4, or at end of life, and say that, I tried everything. So people will come and say, I have this product and it works, it gives amazing results, and all they gave was actually steroid infused stuff which makes you feel good for the moment. And then they call, just name it, I've heard it, this juicing technique. And then you go and get some daun belalai gajah, I don't know what it's called, it's supposed to be something that cures everything. So you really don't need pharma companies if you have leaves like that, isn't it? But when we are in desperation, we will try everything. But which
Yes.
is why I said earlier, maintain realism, be a realist. If there's such results, then that it definitely would have been acknowledged by the ministry scientifically, right? So it's no harm trying, but know where to draw the line. And like what Dr. Ravi said exactly, some medications can interact. Always speak to your physician. We are not against these medication modalities, but it is important that we know so that we can tailor it according to patient needs. We do respect patient autonomy, but it is important that we know what's going on in the background.
Yeah, I'm sorry, we will not be able to consult on the burning or swollen dick sensation if you're taking homeopathic medicine, but I'd be concerned if I had that level of side effects from homeopathic medicine. You're not supposed to. If you understand what homeopathic medicine does, you're not supposed to have side effects. So I'm concerned that there may be other things going on that you may need to go and check with your doctor on that. Okay. Okay, this is a very interesting question, and I really hope we have a little bit of time. I know I'm stealing like a lot of time now, but since those who have had to leave have left, I do want to ask this question, because I find it fascinating. If there's no cure, why do you encourage patients to do the treatment? I think Dr. Ravi mentioned earlier, one reason is because the patient has an event they want to go to. So they want to live long enough to be part of an event. So they go for treatment. But if there's really no cure, why go for treatment for certain things? Any of the doctors want to chime in?
Yeah, so I'll just reiterate what I mentioned just now. I think it depends on the goals of care, right? So for nobody wants to die, right? If they can live longer, why not? But they want to live with good quality of life. So treatment provides both to a great extent. If in many cases, even in stage 4 disease now, prostate cancer, for example, people can live beyond 5 years. right? Because it's a hormonally driven therapy. Breast cancer as well, stage 4, depending on whether you're ER/PR, HER2 positive, you can also live for a long time, many years. If you don't take treatment, you'll live 3 to 6 months. But with treatment, you can live even up to 10 times longer if you are responding to it. So one is quantity of life, quantity, right? You live longer, you spend time with family and all. Second is, even though it's not curative, if the disease shrinks, you have less symptoms. Let's say you had a whopping big tumor pressing on some nerves or causing damage to organs. If the disease shrinks and you're able to kill the cancer, you will feel better. You'll feel better. Your appetite will improve. So there are many patients on chemotherapy. You think the appetite will be terrible, but some of the new types of targeted treatment and all that, actually the side effects are not bad. Immunotherapy, but the tumor shrinks. So you actually feel better over time while on treatment. So why not? You live longer and you can feel better. That's the purpose in giving the medication. So even though it's not curable, you can achieve both these goals with some of the therapies that we have out there. So otherwise, actually, you're absolutely right. If they can't provide either one of these things, then there's actually no point.
The slight point sometimes comes from the mental health side of it. What do you think, Miss Anusha? As the final closing words?
I guess sometimes it's also just having that space to accept, right? It's that it's grief is not something that can happen within a day. Acceptance takes time. So sometimes it's just with medication, they are in a better state of mind because they're not in so much of pain. And that allows them to lead the rest of their life in a meaningful way. So it's not just a quality of life, but it's meaning-centered life. And so if the medication, if the treatment can actually provide them to lead the next 12 months or even 3 months or even 1 week in a meaningful way, and I think that's on us to provide that to the patient.
It also reduces fear, because if you say there's nothing that you can do, fear tends to be very, very great.
Yeah, and hope is an amazing thing.
Yeah.
Yeah.
Yeah. All right. So just the last few words from the panel before we sign off. So just to sign off, I'll start again with Dr. Ravi, since he's on.
Yeah. So I think you nicely have summarized, all the key kind of messages here. I think we obviously don't have enough time to answer every single question, but I think all I want to say is people should go away with the message that having terminal cancer is not the end of the world, and they shouldn't give up, and they should actually seek proper medical advice and have a frank discussion with their family members and not withhold information from family members. Thank you.
Okay, Dr. Malar?
Okay, since the gist of this webinar series lies around aging, I'm just trying to advocate that aging is inevitable. Aging is inevitable, death is inevitable, but aging well, aging with a quality of life that is preserved to the best potential point is something that is doable, and everyone should invest in it.
Okay, thank you. Ms. Hanusia?
I think for me, it would really just be important for all of us to remember that we're not doing this alone, that there is family, there are friends, then there is community and professionals who are all working together with one aim, which is to help the patient to have a better quality of life, to have lesser pain, and just, there's a lot of love and care. So you don't have to feel that you're alone in dealing with this.
Okay, thank you, everybody. And from my side, I'm glad that we've provided some resources. The resources are in the chat box. There are certain NGOs that you can approach. The admin of the team may look at actually setting up a support group, a more active support group for everybody. And we hope that if that support group comes about, everybody can join as volunteers and not just as members seeking help, right? Thank you very much for being part of this webinar. We hope to see you all again in the next round of webinars on the 22nd. Thank you so much. Have a great day. Goodbye. Okay, goodbye.
Thank you, everyone.
Bye.
Thank you so much for making this 20 minutes longer and everybody indulging us for 20 minutes.
Thank you so much for having us. Thank you.
Thank you. Bye-bye.
Bye.
Yes.